Hello everyone, my name is Seung-Jin Lee, Associate Professor in the Department of Cardiovascular and Thoracic Surgery, Suncheon University Hospital, Cheonan. First of all, thank you so much for having me here, C-Week 2018. Today, I would like to talk about the development process, surgery procedure, and the results of so-called double bar in minimal invasive repair of pectus excavatum. As you know, there are two main approaches in surgical correction of pectus excavatum. The first one is Rabbit's procedure and its modifications, which is open procedure and still used in practice. The second approach is Nuss procedure. This is the most widely used technique for surgical correction of pectus excavatum at the time due to a variety of advantages. However, open procedure advocates raise concerns regarding Nuss procedure's complications such as bar displacement. In 2008, Professor Park, chair of C-Week, explained the mechanism of development displacement well. I also have encountered the occurrence of bar displacement after a surgical correction of pectus excavatum and tried various ways to prevent the complication, but most of them turned to be disappointing. After years of effort, in December 2010, we finally developed a rotatable bar, a prototype of double bar. A rotatable bar is designed to hold the entire interior chest wall by using two bars, which results in structurally precluding bar displacement. To use a rotatable bar in the practice, we needed to overcome various challenges. The biggest challenge was to put the two overlapped bars in the right position and fix them using bolts in the body. Fixing the right size was not that much difficult, but it required a lot of challenge to fix the left side after fixing the right side. We almost climbed on the patient's body and tried to fix the bar. To overcome this challenge, that is to fix the bars, we developed an old form of bar approximator so as to put the two bars exactly overlapped and tightly compress the two bars. Unfortunately, it was hard to deliver a force to the right place using this bar approximator. However, from development of this instrument, it began to fix the bars outside of the body. Then, a case was occurred that cruciform-shaped bolt headline was faded out, in other words, damaged. Since the bolt headline was damaged, when the bars were inserted way higher than the desirable position, it was impossible to remove the bars from the body and reinserted them again in the right place. Regardless of this issue, the shape of the chest wall seemed improved, although it was not in the perfect shape. So we decided to finish the operation. Through this experience, the revised form of bar approximator was developed to tightly compress the two bars. Also, star-shaped bolt head was adopted to reduce the possibility of faded out of bolt headline. Additionally, external shape of the bolt head was changed to hexagonal shape so that it can be manipulated by using hexagonal wrench when the bolt headline is damaged. During the follow-up of the outpatients, we observed that continuous breathing exercise can remodel the chest wall like orthodontics. Let's see the picture. The part this black arrow indicates was elevated right after the surgery. In the previous surgery technique, the elevation of this part was even more exacerbated, while in double bar it was getting better, showing symmetrically corrected. This clinical observation suggested us that principle of double bar correction is different from that of single bar one. In single bar, the first lever roll was employed by serving both sides of the rib as pivot points, while in double bar, the second lever roll was applied. Also, the way of bending the bar was altered. Compared to single bar, double bar is absolutely held by compression, which allows us not to necessarily stick the end of the bar to the chest wall, and this will not prevent the growth of chest wall. Furthermore, in double bar, the point of bar insertion is different from that in single bar. In double bar, bars are inserted in the little bit more lateral side so as to unfold the band. Here is a procedure of double compression and complete fixation bar system, so-called double bar surgery, conducted in our hospital nowadays. First, do marking and measure interval between the mid-axillary lines in order to choose the proper bars. Choose upper bar as 10 mm shorter than the lower bar. Mark on bars and bend them. This is trans-illuminated introducer used in our hospital. Check the transmitted light and dissect anterior media staining. Insert and extract the slightly more lateral side. Insert lower bar using chest tube as a guide. Crest is formed on the right side. Create a path for upper bar on subcutaneous layer. The upper bar also is inserted using chest tube as a guide. Two bars are fixed using two bolts on outer right side of the body, and pivot point of the second lever roll is made. On the left side, compress chest wall using bar approximator. And also using two bolts, conduct complete fixation. Insert the bar end, located in the outside of skin, into subcutaneous layer. Because of limited time, results are provided in this table. That's it. Thank you for your attention.